millions of people, they just blindly click accept on a software update without reading a single word of the terms and conditions.
Oh, yeah. Nobody reads those. I definitely don't.
Right. I mean, it is just a universal habit at this point. We see this massive wall of terrifying legal jargon we assume is just, standard boilerplate stuff. And we just want to get to the new features on our phone.
Yeah, you just want the app to open.
Exactly. But think about what happens when that exact same terms and conditions document is attached to a physical pill you are about to swallow.
Right, that changes the stakes completely.
It really does, because, you pick up a prescription and you see that tiny, incredibly tightly folded up piece of tissue paper stapled to the pharmacy bag.
The CVS receipt of doom, basically.
Yes, and what do? We just toss it right in the recycling bin.
Yeah.
I mean, most people accept this physiological update to their body without having any real understanding of the actual safety profile.
None at all. They just trust the process.
Right. And what happens when the fine print on that paper mentions, oh, by the way, your Achilles tendon might suddenly rupture?
I mean, that is the ultimate blind spot in modern healthcare, really. When you ignore a software update, maybe, an app tracks your location for a few days.
Right. Annoying, but not fatal.
Exactly. But when you ignore a medication insert, the stakes are potentially life-altering. We are operating in this environment where we have, frankly, more medical data at our fingertips than any generation in human history.
Oh, easily. We have everything in our pockets.
Yeah, yet the confusion surrounding basic, everyday prescription medications is just profound.
Which is exactly why we are here. Welcome to the Deep Dive, everyone. Today we are exploring this massive gap in the medical world.
And it is a gap we all fall into, whether we realize it or not.
We really do. So we are looking at the critical intersection of medication safety, patient education, and the indispensable role of independent medical information platforms.
Which is a very specific but very important niche.
It is. And to do this, we are using a really fascinating lens today. We are looking incredibly closely at one specific topic.
Ciprofloxacin 500 milligrams.
Exactly. Ciprofloxacin 500 milligrams, clinical utility, and patient safety implications. The core question we are tackling today sounds deceptively simple, honestly.
Oh, it always does.
Right. The question is just, what is ciprofloxacin 500 milligrams actually used for?
Which, sounds like a query you just quickly type into a search bar to get a one-sentence answer.
Yeah, like, oh, it fixes a cough. Boom. Done.
Right, but the reality of that question, like the actual medical reasoning behind why a specific dosage of a specific drug is chosen for a specific human body, it is vastly more complicated.
And to navigate all of this complexity for you, the listener, we are looking at the work of independent medical information platforms.
Specifically focusing on the model used by platforms like iMedix, right?
Yeah, exactly, iMedix.
Yeah.
Because they operate with these dedicated editorial and medical research teams, and they maintain these really comprehensive drug databases and patient education resources.
Which is no small feat, honestly.
No, it's huge. And our mission today is to figure out why smart, otherwise very capable people frequently completely misunderstand medication risks.
Even when the data is right there in front of them.
Right. And we want to see how these independent platforms clarify those misunderstandings and how analyzing a drug's utility really requires looking at the regulatory context and the real-world impact.
Because you can't just read a generic drug monograph and actually understand what it means for your body.
You really can't. And I think the word independent is doing a monumental amount of heavy lifting in this ecosystem, don't you think?
Oh, absolutely. I mean, in the traditional medical information landscape, true independence is surprisingly rare.
Wait, really? Rare in what way?
Well, think about where drug information traditionally originates. First, you have the pharmaceutical companies themselves.
Right, the people making the pills.
Exactly. And their primary goal, naturally, includes marketing, selling the drug, and, strictly limiting their legal liability.
So they write those pamphlets to protect themselves, not necessarily to teach me.
Precisely. And then on the other side, you have the regulatory bodies, like the FDA or the EMA, whose job is to provide legal and safety guardrails.
The rule makers.
Right. But neither of those entities is structurally designed to sit down and teach the patient.
Yeah, that makes sense. They aren't educators.
No, they speak in legalese or they speak in marketing copy. They don't speak patient.
It's like they're handing you a dictionary and expecting you to speak a fluent foreign language by the time you literally walk out of the pharmacy.
That is a great way to put it, yeah. What an independent platform with a dedicated editorial and medical research team does is essentially act as a translator.
Okay, a translator. I like that.
Yeah, they sit right between the impossibly complex raw medical data. I mean, clinical trial outcomes, the pharmacokinetic profiles, all those adverse event reports, and the actual patient.
Wait, hold on. You just mentioned pharmacokinetic profiles.
Oh, right, medical jargon. My bad.
Let's translate the translator for a second. For the sake of clarity, we are basically talking about the journey the drug takes through the body, right?
Yes,
Like
exactly.
how it is absorbed in the gut, how it gets distributed into your tissues, metabolized, and then eventually cleared out.
You got it. It's the entire life cycle of the drug inside you.
Okay, so how does an independent platform translate that?
Well, the raw data from the manufacturer might say something like, ciprofloxacin exhibits a volume of distribution of 2.1 to 2.7 liters per kilogram.
Which means absolutely nothing to me.
Exactly. To a patient, that is meaningless noise. But to an editorial medical team, that specific data point means the drug is excellent at penetrating deep into tissues rather than just floating around in the bloodstream.
Oh, wow. Okay.
So the independent platform's job is to take that raw, dense data and explain to you, hey, this drug is prescribed for your kidney infection because it is specifically designed to soak deeply into kidney tissue.
That makes so much more sense.
Right, it turns raw numbers into an actual reason.
I hear you on the curated databases, and, the translation aspect makes perfect sense in a vacuum.
But I feel a but coming.
Yeah. Honestly, let me play the skeptic for a minute here.
Go for it.
If my doctor, who went to medical school for a decade, completed a grueling residency, and has been practicing for years, tells me to take a pill and explains it during my visit,
Right.
why do I need to go home and cross-reference them on iMedix? Isn't that just breeding, medical paranoia?
That is a very common concern.
I mean, are we overcomplicating a relationship that should just be between a physician and a patient?
It is a totally valid skepticism, but the reality of clinical practice today dictates otherwise.
How so?
Well, the very existence of these massive independent databases and their incredibly high traffic volume proves that the standard doctor's visit simply isn't enough.
Because people are still confused when they get home.
Exactly. And the thing is, it is rarely the doctor's fault. It is a structural flaw in the whole system.
Right. They only have, 15 minutes per patient?
If you're lucky. And think about the patient's state of mind. When a patient is sitting in an exam room, they are often stressed, they might be in significant physical pain, and their cognitive load is just completely maxed out.
Oh, absolutely. The adrenaline takes over.
Right.
You are just trying to process the fact that you have a serious infection or whatever the diagnosis is.
And studies consistently show this. Patients forget up to 80% of the medical information provided to them by healthcare practitioners the literal moment they leave the clinic.
Wait, 80%? That is a staggering number.
It is. They get home, the adrenaline fades, they look at the little orange bottle, and suddenly they realize they have absolutely no idea what the doctor meant when they said, monitor for neurological symptoms.
Yeah, or they can't remember if they're supposed to take it with food or on an empty stomach.
Exactly. So the independent platform isn't redundant. It is the necessary safety net for the psychological realities of how human beings process medical stress.
Okay, that makes a lot of sense. Let's look at the actual mechanics of that safety net, because I find this editorial curation process fascinating.
It really is a unique editorial challenge.
How does a team at a place like iMedix actually decide what makes the cut? I just imagine this intense editorial meeting where you have pharmacologists, medical writers, and researchers all staring at a 500-page clinical trial document.
That's essentially what happens, yeah.
And they have to decide what the patient actually needs to know to be safe versus what will just terrify them unnecessarily. They're structuring the info to be, cognitively digestible.
It requires a profound level of empathy combined with really strict clinical rigor.
Empathy is an interesting word to use there.
Well, you have to put yourself in the patient's shoes. The editorial team has to anticipate the public's knowledge gaps. They look at search trends, for example.
After they are seeing what people are actually confused about in real time.
Exactly. If thousands of people are suddenly querying a specific interaction between, say, a new antibiotic and their daily blood pressure medication, the editorial team knows they need to push contextualized, peer-reviewed content addressing that specific fear.
That is brilliant. It is a dynamic feedback loop.
Right, which is something a static paper pamphlet from 2018 simply cannot provide.
Which brings us to a massive shift in the medical power dynamic, I think.
Oh, unquestionably.
If independent drug databases become the primary trusted resource for patients after they leave the clinic, we are moving away from an era where the patient is just a passive recipient of a directive.
The old doctor knows best, don't ask questions era.
Right. Take this twice a day, don't ask questions. We are moving toward empowering objective medical literacy.
It democratizes the entire healthcare process.
How so for the average listener?
Well, when you have access to high-level, understandable medical literacy, you become an active participant in your own body. You can actually have a sophisticated dialogue with your prescriber.
You aren't just nodding along blindly.
Exactly. You can say, hey, doc, I reviewed the safety profile of this 500 milligram dosage on an independent platform, and given my history of joint issues, is there an alternative?
Wow. Yeah, that fundamentally alters the traditional, somewhat patriarchal structure of medicine into a true collaborative partnership.
It empowers the patient to be part of the care team.
Okay. But if they're doing all this translating and empowering, we have to ask a blunt question.
Shoot.
What exactly are patients getting so wrong when they try to read the raw data themselves? Why does the human brain struggle so mightily to understand a simple side effect list?
Human psychology is terrible at processing risk. It usually comes down to the brain's inability to accurately weigh two conflicting concepts:
Which are?
clinical utility against safety implications.
Okay, unpack that for me.
When human beings look at raw data, we struggle to contextualize probability. We are victims of our own cognitive biases.
Right, we are terrible at math when we are scared.
Exactly. Let's say a specific side effect has a 1 in a million chance of occurring.
Okay, like struck by lightning odds.
Right. But if it is listed in a pamphlet right next to a side effect that has a 1 in 10 chance of occurring...
It's mild nausea or something?
Yes. The brain often weighs them equally simply because they occupy the same visual space on the page.
The visual hierarchy implies equal risk.
Yes.
You read, may cause mild nausea.
Yeah.
Right underneath it, in the exact same font size, it says, may cause fatal internal bleeding.
And the brain just panics.
Of course it does.
And that panic, or the opposite reaction, which is complacency, are the two dangerous extremes of operating without context.
Tell me about the complacent patient.
The complacent patient looks at that massive list and thinks, oh, every single drug has a million side effects listed just so the company doesn't get sued. I'll just ignore all of it.
I've definitely been that patient.
We all have. But then you have the panic patient. They think this drug lists fatal bleeding. I am absolutely not taking it.
Even if the risk is infinitesimally small.
Exactly. Even if the clinical utility, say, the benefit of taking the drug to prevent a massive, highly probable heart attack is overwhelmingly high. Our psychology of risk assessment is heavily flawed.
Doesn't a database just add more noise, though?
What do you mean?
Well, if people are naturally prone to misunderstanding risks, and our brains are wired to mess up probability, how does providing more information on an iMedix platform actually solve the problem?
I see.
I mean, if they ignore the pamphlet, won't they just get overwhelmed by the database too?
That is the critical distinction. The solution independent platforms offer isn't more information.
It's not.
No, it is contextualized information. Giving someone raw data is adding to the noise.
Right.
Giving someone an article that says, here is exactly how this drug works. Here are the 3 specific side effects you actually need to monitor based on your age and demographic, and here's how they might physically feel in your body.
Oh, that is so much better.
It strips away the noise, it focuses the attention, it turns raw, terrifying data into a manageable mental framework.
Let's see that contextualization in action then, because I want to really ground this.
Good idea.
We are anchoring this discussion on our specific case study. Ciprofloxacin 500 milligrams, clinical utility and patient safety implications.
A classic, complex medication.
Right. And the driving question we need to answer for the listener is, what is ciprofloxacin 500 milligrams actually used for?
And we aren't going to just paste a list of FDA-approved diagnoses here.
No, absolutely not. That would be so boring. We need to look at the medical reasoning behind the utility.
To understand the utility, we really have to look under the microscopic hood of this drug.
Okay, let's pop the hood. Where do we start?
Ciprofloxacin belongs to a class of antibiotics known as fluoroquinolones.
Fluoroquinolones, okay.
Now, most people are familiar with everyday antibiotics like penicillin or amoxicillin.
Yeah, the pink bubblegum medicine from when we were kids.
Exactly. Now, those older drugs generally work by attacking the bacterial cell wall.
They break down the outer shell.
Right. They compromise the structural integrity of the bacteria, the wall bursts open, and it falls apart. But ciprofloxacin operates on a completely different, much deeper level.
Wait, so it bypasses the wall entirely?
It does. It essentially walks right through the front door, penetrates deep into the bacteria, and targets the actual enzymes responsible for DNA replication.
Oh, wow. It goes straight for the source code.
That is exactly what it does. Specifically, it targets enzymes called DNA gyrase and topoisomerase III.
The poisomerase the yethy. Say that 3 times fast.
I try not to, but here is why they matter. Bacterial DNA is tightly supercoiled, kind of like a twisted, knotted rubber band.
Okay, I can picture that.
For the bacteria to replicate and survive, it has to temporarily uncoil that DNA, copy it, and put it back together.
Otherwise, it can't divide.
Right. And these specific enzymes, they do the cutting and the resealing of the DNA strands.
So what does ciprofloxacin do to that process?
It is brutal. It physically jams those enzymes right after they have cut the DNA, but before they can seal it back up.
Oh my God.
The bacteria is just left there with its own genetic code completely shattered into pieces.
That is wildly effective.
It is. It cannot replicate, it cannot repair itself, and it dies rapidly. Because it targets such a fundamental mechanism, ciprofloxacin is incredibly potent.
So it's not messing around with walls, it's just shredding the blueprint.
Exactly. And that is why it is considered a broad-spectrum antibiotic. It can eradicate a very wide variety of bacteria, particularly what we call in medicine gram-negative bacteria.
Ah, gram-negative. You see that term constantly in antibiotic literature.
You do, and it confuses a lot of patients.
For the listener trying to build that mental framework, a gram-negative bacterium basically has an extra incredibly tough outer membrane, right?
Yes, it could.
And that extra membrane makes it highly resistant to a lot of standard antibiotics. It's almost like a bacterium wearing a suit of armor.
That is a perfect analogy. That outer lipid membrane keeps out a lot of the older, narrower spectrum drugs like penicillin. They just bounce right off the armor.
But ciprofloxacin slips right through.
It slips right through the armor and goes straight to the DNA. So when we ask what is it used for, the medical reasoning points directly to infections that are stubborn, deep-seated, heavily armored, or highly resistant to other typical treatments.
Which brings us to the actual dosage, the 500 milligram part. Why 500 milligram?
It's a very specific number.
Right, why not 100 milligram or, I don't know, a full 1,000?
It all comes back to those pharmacokinetic profiles we discussed earlier, the journey through the body.
Okay, tie that together for me.
The 500 milligram dose, which is usually taken twice a day, is meticulously calculated to achieve what pharmacologists call the minimum inhibitory concentration, or MIC.
Minimum inhibitory concentration, so the lowest amount needed to actually work.
Exactly. You need enough of the drug flowing through the blood and penetrating the specific tissues to completely halt that bacterial DNA replication.
What happens if you take less, say, 250 milligram for a severe infection?
If the dose is too low, the bacteria survive. Worse, they mutate and become resistant.
Oh, right. You don't want to just make them angry.
Exactly. But if the dose is too high, the risk of severe side effects to the human host absolutely skyrockets.
So 500 milligrams is the Goldilocks zone.
It is. The 500 milligram dose hits the necessary concentration in key tissues, like the urinary tract, the prostate, and the gut, while maintaining a half-life in the body that allows for convenient 12-hour dosing intervals.
That makes perfect sense. So let's look at the specific infections where this utility really shines.
The primary targets.
Right. The data points heavily toward urinary tract infections, gastrointestinal infections, and then selected respiratory or skin infections when appropriate.
Let's break down urinary tract infections first, because this is where comparative medical reasoning becomes incredibly vital.
Okay.
You would not and should not typically use ciprofloxacin 500 milligrams for a routine, uncomplicated UTI in an otherwise healthy individual.
Right, because taking ciprofloxacin for a mild UTI is like calling in a military airstrike to take care of a termite problem in your shed.
That is visually very accurate.
I mean, yes, the termites are definitely gone, but you've also leveled the entire neighborhood, shattered all windows, and left behind radioactive fallout in your yard.
You want to use an exterminator first.
You want to use a fly swatter.
Exactly. The fly swatter, in this medical scenario, being a first-line agent like nitrofurantoin or sulfamethoxazole.
The basic stuff.
Right. They handle the basic bacteria safely and effectively, but if that UTI becomes complicated...
Complicated how?
Say the infection ascends out of the bladder, travels all the way up the ureters, and infects the kidneys themselves, causing a serious condition called pyelonephritis.
Oh, so it's moving deep into the organ.
Yes. At that point, the clinical utility of ciprofloxacin changes completely. The airstrike is now absolutely necessary.
Because the fly swatter isn't going to save your kidney.
Exactly. Ciprofloxacin is uniquely excellent at penetrating deep kidney tissue and achieving massively high concentrations in the urine.
So it flushes the whole system out?
It makes it a critical tool for eradicating those tougher, deeper infections before they cause permanent organ damage, or worse, enter the bloodstream and cause sepsis.
Wow. Okay, what about gastrointestinal infections? Because the gut is an incredibly complex microbiome all on its own.
It is, and again, context is key. Most common GI bugs, the kind that cause your standard weekend food poisoning.
The bad sushi regret.
Right. Those resolve on their own with just rest and hydration. But if a patient has severe systemic traveler's diarrhea caused by a highly virulent strain of E. coli or a nasty salmonella infection that threatens to spread beyond the intestines,
Then you bring in the big guns.
then ciprofloxacin is deployed. Its ability to hit a broad range of those armored gram-negative gut bacteria makes it highly effective at clearing severe pathogens quickly.
Now, I notice in the documentation the phrase, when appropriate, is heavily attached to respiratory and skin infections.
And for very good reason. This is a big area of medical reform.
Really? Why?
Well, for decades, fluoroquinolones were massively overprescribed for basic bronchitis or simple skin abscesses.
Just hand it out like candy.
Unfortunately, yes. But the current medical consensus, which is entirely driven by safety data, is that for things like acute bacterial exacerbation of chronic bronchitis or an acute uncomplicated sinusitis.
A sinus infection.
Right. For those, ciprofloxacin should only be used if the patient has absolutely no other alternative treatment options.
Oh, wow. So it's been downgraded for those uses?
It is heavily restricted now. It is a drug of absolute last resort for those specific conditions, reserved for cases where the bacteria have proven resistant to literally everything else.
Focusing on the medical reasoning here, the fact that ciprofloxacin attacks the bacterial DNA machinery and is deployed like a special ops unit for deep tissue armored infections, it makes the drug make sense.
It gives it a narrative.
Exactly. It's not just a generic, unpronounceable chemical name anymore.
But, and this is a massive but, balancing that utility requires us to look at the other side of the coin.
The dark side.
You cannot ethically discuss the clinical utility of fluoroquinolones without deeply, deeply analyzing the safety implications.
Yeah, we have to zoom out and look at the broader regulatory landscape here. Because ciprofloxacin carries some notoriously intense safety warnings.
Very intense.
We are talking about black box warnings from regulatory bodies like the FDA.
Which is not something to take lightly.
For anyone unfamiliar, a black box warning is the strictest, most severe warning a prescription drug can carry before it is just pulled from the market entirely.
It is the FDA screaming for your attention.
It literally has a thick black box drawn around the text on the warning label to demand the prescriber's and the patient's attention.
And the warnings associated with ciprofloxacin and other fluoroquinolones are profound.
So what are we looking at?
We need to examine the relevant regulatory context and clarify the practical safety implications, specifically regarding three main areas: tendon injury risk, neuropathy concerns, and central nervous system effects.
Okay, let's take the tendon injury risk first, because a generic warning label just says, may cause tendon rupture.
Which sounds completely random.
Right. How does a drug that is designed to jam an enzyme inside a microscopic bacterium end up snapping the Achilles tendon of a full-grown human being?
The underlying biology is absolutely fascinating and, quite frankly, troubling.
Walk me through it.
Okay, we know ciprofloxacin disrupts bacterial DNA enzymes, but it turns out fluoroquinolones also have a remarkably high affinity for connective tissue in humans.
Why connective tissue?
Because they are known to chelate, or basically chemically bind to, certain essential minerals in your body, primarily magnesium.
Magnesium, okay.
Now, magnesium is a critical essential component for maintaining the structural integrity of collagen matrices.
And collagen is the stuff in our joints, right?
Yes. Collagen is the primary protein building block of your tendons, your ligaments, and your cartilage.
So by binding to the magnesium, the drug is essentially pulling the mortar out from between the bricks of your connective tissue.
That is exactly the right visualization. It pulls the mortar out.
I'm like,
It disrupts the cellular homeostasis of the collagen. It degrades the structural integrity of the tendon from the inside out.
that is horrifying.
It can lead to severe tendinitis very quickly, or in catastrophic cases, a complete tendon rupture.
And the Achilles is usually the one to go.
The Achilles tendon is the most commonly affected simply because it bears so much of the body's mechanical load every time you take a step.
But wait, this is where what we talked about earlier comes in. What independent platforms do so well is contextualize who is most at risk.
Exactly. This is where the context saves lives.
Right, because not everyone who takes ciprofloxacin snaps a tendon. obviously, or it wouldn't be on the market. There are risk multipliers.
Right. Massive multipliers. The risk doesn't hit everyone equally.
Who is at the highest risk?
Well, the risk goes up exponentially if you are over the age of 60.
Because your collagen regeneration is already naturally slowing down with age.
Precisely. You have less mortar to spare. The risk is also severely compounded if you are simultaneously taking corticosteroid drugs, like prednisone, because steroids also weaken connective tissue.
Oh, double whammy on the joints.
Or if you've had a solid organ transplant, like a kidney or a heart transplant, your risk profile is through the roof.
That context is everything. Think about it. If an older patient who is on a steroid inhaler for their asthma gets a complicated UTI,
Right.
an independent platform highlighting that specific combination of risk factors allows them to have an informed conversation with their doctor.
They can say, wait, I'm over 60 and on steroids. Can we choose a different antibiotic class entirely?
Exactly. It turns this abstract fear of a black box warning into a personalized safety protocol.
It is precision medicine driven by patient education.
Okay, what about the nerves? Because you mentioned peripheral neuropathy concerns next.
Yes, this is damage to the peripheral nervous system.
Just to clarify, that's the vast network of nerves that transmits information between your brain and spinal cord to the rest of your body.
Right. The wiring of the body, yes. Down your arms, your legs.
Okay, so what does the drug do to the wiring?
Fluoroquinolones can actually cause damage to the axons or the myelin sheaths of these nerves.
The myelin sheath is like the rubber insulation on a copper wire, right?
Exactly. It strips the insulation. Patients experience this as extreme weakness, a strange burning numbness, or sharp shooting pain, usually starting in the hands and feet.
That sounds awful.
It is. But what the regulatory warning context highlights, and what patients desperately need to know before they take the first pill, is that this neuropathy can occur rapidly.
Like how fast?
Within a few days of starting the medication. And in some documented cases, the nerve damage has been permanent, continuing for months or years long after the drug is stopped.
Wait, permanent nerve damage from a few days of antibiotics, that is terrifying.
It is a severe implication, which is why it carries that black box warning.
And it goes even deeper than the peripheral nerves into the central nervous system, right? The brain itself.
It does. Ciprofloxacin has the unique ability to cross the blood-brain barrier.
For our mental framework here, the blood-brain barrier is basically a highly selective security checkpoint, right? It protects the brain from toxins and pathogens that are circulating in the general bloodstream.
Most drugs just bounce right off the security guards.
But ciprofloxac's chemical structure allows it to slip through the checkpoint.
Yes. And once it is inside the central nervous system, it can drastically interfere with neurotransmitter activity.
What exactly does it do to the brain chemistry?
Specifically, it can act as an antagonist to GABA receptors.
GABA.
Yes. GABA is a major inhibitory neurotransmitter. It essentially calms the brain down. It keeps your neural activity smooth and regulated.
So ciprofloxacin blocks those calming signals. The brain becomes hyperexcitable.
The brakes are cut.
Wow, the brakes are cut.
Precisely. The neurons just start firing without regulation. This can lead to a huge range of CNS effects.
Like what?
Well, on the milder end, you might experience dizziness, severe insomnia, or just a heavy brain fog.
Unpleasant, but survivable.
Right. But on the severe end, extreme anxiety, paranoia, vivid hallucinations, and in rare but documented cases, actual grand mal seizures.
Seizures from an antibiotic.
Because the GABA brakes are gone.
When you lay out the biological mechanisms like that, the collagen degradation pulling the mortar out, the myelin sheath damage stripping the wires, the GABA receptor blocking, cutting the brakes, it becomes incredibly clear why the regulatory guidance has shifted so dramatically over the last decade.
It really clarifies exactly when ciprofloxacin is preferred versus when it absolutely must be avoided.
It's a high-stakes balancing act.
The comparative medical reasoning here dictates that the clinical utility must definitively outweigh these severe safety implications.
Right.
If you have a life-threatening infection, like, say, systemic anthrax exposure.
Anthrax, okay, extreme example, but sure.
Or a severe, complicated intra-abdominal infection where the bacteria has proven resistant to all other classes of drugs, then ciprofloxacin is absolutely the preferred weapon.
Because the immediate risk of the infection literally killing you outweighs the potential risk of a tendon rupture or neuropathy.
Exactly. You accept the risk to save the life.
But if you just have a standard run-of-the-mill sinus infection, the risk matrix flips completely.
Completely. The risk of the drug is suddenly worse than the disease. And this ties into a much larger global issue that independent platforms spend a lot of time educating on:
Which is?
antimicrobial resistance.
Ah, the superbugs.
Yes. Appropriate prescribing contexts are not just about protecting the individual patient from a tendon rupture. They are about protecting the entire human population from superbugs.
Antimicrobial resistance is often called the silent pandemic, isn't it?
It is one of the greatest threats to modern medicine.
Because if we constantly use our heavy artillery, our airstrikes like ciprofloxacin, for minor infections, the bacteria don't just all die.
No, the strong ones survive.
Mm-hmm.
And the ones that survive mutate. They learn.
How do they learn?
They literally share genetic information with each other. They develop physical defense mechanisms.
Right. Like the armor we talked about.
Even more advanced than that, they develop things called efflux pumps.
What is an efflux pump?
It's a mechanism that literally pumps the antibiotic back out of the bacterial cell before it can even reach the DNA enzymes.
Wait, the bacteria physically bails the drug out like water from a sinking boat?
Exactly. And if we overuse fluoroquinolones for simple colds, we actively breed bacteria that are completely immune to them because they've built so many pumps.
That is terrifying.
And then when a patient comes into the ICU with a life-threatening deep tissue infection and we actually desperately need the ciprofloxacin to save their life,
It fires blanks.
if fires blanks, the bacteria just shrug it off and keep multiplying.
So independent platforms like iMedix, by educating patients on why they shouldn't just go into the doctor and demand a powerful antibiotic for a simple viral cold, they are actually playing a huge role in the fight against global antimicrobial resistance.
They are completely on the front lines of it. Educated patients are far less likely to pressure their doctors for unnecessary antibiotics.
Right, because they understand the stakes now.
It is a perfect example of how contextualized information creates systemic global change.
I can honestly envision a future where these regulatory warnings and real-time resistance patterns are integrated directly into patient education tools.
How do you mean?
Well, imagine if a new resistance pattern emerges in a specific city, or, a new warning regarding collagen degradation is issued by a regulatory body in Europe.
Oh, like a live feed.
Yeah. An independent database could instantly update how treatment questions are answered for users in that specific region.
Yeah.
It becomes a live, breathing shield against medical errors.
That is the ultimate goal. It proves that critical thinking cuts through information overload.
It really does.
Providing the why behind a regulation simplifies the patient's understanding. If you just hand someone a list of 50 terrifying side effects on a piece of tissue paper, they are paralyzed.
Or complacent.
Right. But if you explain how the drug works, why it's reserved for severe cases, and the actual mechanics of the risks, it creates a mental framework.
You are forcing them to memorize a warning label.
No, you are helping them understand a biological system.
We have covered a massive amount of ground today.
We really have.
We started by looking at the incredible gap between the raw data that exists and the patient's actual comprehension, and how independent platforms act as these essential translators.
We unpacked the cognitive biases that cause us to completely misunderstand risks when we just look at raw data.
Right, the visual hierarchy of the side effect list. We examined the clinical utility of ciprofloxacin 500 milligrams, understanding its specific mechanism of jamming bacterial DNA.
It's a poison race.
Exactly. And why that specific mechanism makes it the preferred heavy-duty choice for complex UTIs and severe GI infections.
And crucially, we balance that utility by exploring the very real biological mechanisms behind those black box warnings.
The magnesium chelation pulling the mortar from the collagen, leading to tendon ruptures.
The blood-brain barrier penetration causing hyperexcitable CNS effects.
And why antimicrobial resistance makes appropriate prescribing so absolutely vital for the whole planet.
The ultimate goal of platforms like iMedix, and frankly the goal of this deep dive, is to transform the medical experience for you, the listener.
It is about moving from being a passive recipient of a prescription, just blindly swallowing a pill, to an active, educated participant in your own healthcare.
Because when you understand the underlying reasons, you hold the power to actually advocate for yourself in the exam room.
I want to leave everyone with a final thought to mull over.
Lay it on us.
We've established that independent editorial medical platforms are the key to translating this raw data and regulatory warnings into actual actionable patient understanding, right?
Yes.
So, What would happen if the medical industry fundamentally shifted its regulatory requirements entirely?
That would be a seismic shift.
What if, instead of pharmaceutical companies writing those dense, legalese, liability-focused warning labels on your prescription bottles,
Yeah.
the industry mandated that independent editorial teams wrote them?
Wow.
Teams specifically trained to prioritize patient comprehension over legal jargon.
It would completely redefine the foundation of informed consent in medicine.
It really would.
Yeah.
Because at the end of the day, we shouldn't have to feel like we are blindly clicking accept on a software update when it comes to the chemistry we're putting into our own bodies.
Absolutely not.
The world of pharmacology might be incredibly complex, but with the right translation and the right context, we can absolutely learn how to navigate it safely.
Well said.
Thanks for joining us on the Deep Dive. We'll see you next time.